Hi, I'm Dr. Mark Studin, and welcome to Stroke. And Stroke for the medical and chiropractic primary care provider, which is basically the average chiropractor. First, I'd like to thank ChiroSecure for giving me the platform to do this. And this is perhaps one of the most important topics in our industry. And really, forget the industry, it's the most important topic to protect the public. Because when we deal with stroke, it's a hot button item, but more than that, you really have to protect the public you're caring for. Because people don't understand that there's doctor of chiropractic is two separate entities in that phrase. We're doctors and we're chiropractors, and sometimes they're mutually exclusive, and sometimes they're highly inclusive. So you have to first evaluate your patient, kind of like you learned in school, but we're going to teach you a little bit of advanced vascular training to determine if your patient is undergoing a stroke incident. And I'll clarify that in a minute. Now you notice across the top it says part 4, because this is actually the fourth part of a stroke course to identify stroke patients in the primary care setting, which chiropractors are. The course was done with Dr. Candace Perkins. She's a double-boarded vascular neurologist trained at Albert Einstein College of Medicine in New York City. She was an assistant professor of vascular neurology at the State University of New York at Stony Brook. She goes all over the country now. She is incredible. So she actually did the 4 parts with me and Dr. Don Capaferri, who did some research, and we did some work on testing protocols, and the late Frank Zolli, who is the dean at the University of Bridgeport Chiropractic College, who's a dear friend who I actually miss tremendously. But we put this course together so doctors would have a complete understanding of the entire vascular system in head and neck and understand risk factors and protocols. And it's an 8-hour program, and I'll talk about this on the last slide. You can take the course if you want to get credentialed at teachdoctors.com. The course is credentialed through the State University of New York at Buffalo Jacobs School of Medicine and Biomedical Sciences and Cleveland University College of Chiropractic. So you get chiropractic credits, medical credits, but more importantly, you get a high level of knowledge from someone who is one of the nation's leading expert on vascular incidences. Stroke incidents happen actually more in medical primary care offices than anywhere in the country, but they do happen within chiropractic office. But what Dr. Perkins said is a chiropractor or MD primary care provider cannot cause a dissecting aneurysm. Cannot. It's not possible. Physiologically, it's not possible. However, too many primary care practitioners miss a patient undergoing it should be 2 words, vascular incident. Undergoing a vascular incident. And that's critically important because you have to understand, let's just take it to the next step. According to Whedon, McKenzie, Phillips, and Lurie in 2015, reported on the safety in general for chiropractic patients, because folks, what I want to share with you is not just opinions. I want to share with you the evidence in the literature. And based upon their study of 6,669,603 subjects, and after the unqualified subjects have been removed from the study, the total number was 24,068,808 office visits. They concluded no mechanism by which a spinal manipulation or chiropractic spinal adjustment induced injury into normal healthy tissues has been identified. This study supersedes all the rhetoric about chiropractic and stroke and renders an outcome assessment to help guide and triage mechanical spine patients. It helps you triage. This is your guiding. This is it, folks. This tells you everything you need to know, up to the point of what else do I need to do. This is the chiropractic part. Now we're going to get to the doctor part, and that's important. Now a stroke, just so you understand, it's a brain attack. It's caused by an interruption of blood flow to the brain. Now, the brain cells in the immediate vicinity die within minutes to hours, and that's called the infarct zone. Ischemic cascade, meaning blood can't get there, is a chain reaction that endangers brain cells in a larger surrounding area of the brain for which the blood supply is compromised but not completely cut off, and that's the penumbra zone. So what happens is, first is infarct, cells die. And then they're going to die in the penumbra zone, which you don't get to it quickly, which is why stroke protocol in a patient is to introduce clot-busting drugs immediately. So you want to not have the penumbra zone become more of the infarct zone. And that's critically important that all stroke is lack of brain to the lack of blood to the brain. So you've got here, that's your brain, that's your dura, and then you have epidural hematoma and subdural hematomas. All of these things, if blood pools in there, blood might not be getting to other areas, and you're looking at that. And actually, a epidural hematoma is actually more dangerous than sub, because what it's doing is it's pooling blood and putting pressure on the brain. There's higher venous pressures on the epidural area than the subdural area. So when we look at stroke and we look at blood not getting to other areas, there's issues of stroke, then there's issues of pressure issues, of which is putting pressure on the brain. It's all about vascular ability to flow, too much or too little, but stroke actually is when you have lack of blood going to an area. Now, a stroke examination is a gross misnomer, gross, because a complete neurological examination is a stroke examination. Most MD primary cares and chiropractors only perform a cursory neurological screening at best, where an acceptable neurological exam can take just a few minutes, folks. Listen, I do compliance reviews on doctors, thousands of them. I cannot begin to tell you how many don't do motor loss, sensory loss. These are just basic stuff, reflexes, basic, and do a complete history, and we'll talk about that in just a moment. But you've got to get to that. Your physical examination, you've got to get in there, and you've got to know motor, sensory, all of these things can be related to stroke. You might have a small bleed, or you might have a small infarct in a large penumbra area. That's affecting the motor, the sensory, cognitive areas. Patient is oriented to time and space. That's the first thing we all learn. That's cognitive. That can be the beginning of a stroke, and you look at other things as well. So when we look at stroke risk factors, you want to look at general and family history. Now, the following risk factors are important in your decision on how to manage your patient. Each factor is not critical, but together they can put a more complete picture. Now, age, a stroke can happen at any time, but stroke risk increases with age. After the age of 55, stroke risk doubles for every decade a person lives. Females have a higher incidence of stroke, where more women die from stroke than breast cancer. Race and ethnicity. Did I say that right? Ethnicity. African Americans have twice the risk of stroke, partially because they're more susceptible to high blood pressure, diabetes, and obesity. Hispanic and Asian Pacific Islanders have a higher incidence than Caucasians. Family. Your stroke risk increases if a family member, mother, father, or sibling had a stroke at an early age. A previous stroke, 25% of them are recurrent. So all of these are risk factors that you need to find out in a history, and it's important. Lifestyle, smoking, excessive alcohol, illicit drugs, especially cocaine, obesity, are all risk factors. We can get into other things that are risk factors that are a little bit more esoteric, more and more disease, a myriad of cancers and other things. It gets a little bit too much into the weeds right now, but you need to find out, are there any specific diseases? Because when I do compliance reviews again, and we go over family social, mother, father, brother, sister, high blood pressure, cancer, diabetes, that's pretty much all I see. Ask, does anyone have any specific diseases, familiar diseases, genetic diseases? It only takes a half a second, but it could lead you to another risk factor. Past medical history of the patient are really critical, especially with auras, sickle cell anemia, dyslipidemia, obstructive sleep apnea, renal failure, deep vein thrombosis, peripheral arterial disease, rash, liver failure here, moya, I talked about that, CADASIL, carotid stenosis, renal artery stenosis, I'm just bouncing around, atherosclerosis, diabetes, previous stroke, radiation, a region of artery such as carotid artery, pain in the neck, in the carotid areas, and migraines. So all of these things, there's dozens of others, and we do go through all of them in detail in the course, which teaches you how to understand at a greater depth. Now, by the way, I urge everybody at the highest level. We've had hundreds and hundreds of doctors already take the stroke course, hundreds. And every single one said, wow. And I was shocked. they said it was possibly the best course I ever took because they have a deep understanding of what to look for. And when a patient comes in, listen, if they have migraines or they simply need to be adjusted, they need to be referred out, do they need to have a head MRI or a CT, or there's a myriad of things. So you need to learn those little nuances. It will make you a better diagnostician. Now, unfortunately, in chiropractic versus medicine is diagnostics over the top and treatment not as much, where chiropractic is the other way around. And because chiropractic works so well, that we often bypass really getting into the weeds and diagnosing the patient. It doesn't make you a medical doctor. That's absurd. It makes you a primary spine care provider, meaning you're going to be the first person they see for spine, the very first. And when they come in with this problem, you need to know what's going on. It just makes you a much better doctor and a patient manager and triager. And when you do that, you're going to start getting busy, folks, because word's going to get out. You're going to get out to your other patients, to other doctors in the community. When you start referring, when I started working with the vascular neurologist and doing this course, and I did a tremendous amount of research, I got a phone call from the neurosurgeon. I understand Dr. Perkins is working with you, and I think that's outstanding. Where's your office? I want to send patients to you. And I said, I'm sorry, I don't practice anymore. Those days are over. Who do you know that's studied at this level? And I sent them a couple of names, and guess what? That person's getting busier. It happens like that all around the country. The better you get, the smarter you get, the busier you're going to get. Now, when we look at risk factors for dissection, whiplash. Now, this is not a chiropractic adjustment. It's going way past the paraphysiological limits. Can overstretch these vessels. And you need to understand certain things so that your patient can be triaged timely and accordingly. Because they might have a slight tear. They might have a small bleeder. Chances are they don't, but they might, and you need to know that. So when you look at specific factors, okay, for dissection specific, all the collagen vascular diseases, in addition to certain types of deficiencies and crazy diseases, you have to ask or get a copy of their medical records. Do you have any of these? Fibromuscular dysplasia, with or without cystic medial necrosis. Trauma, which I just showed you that slide a moment ago. Recent infection with arterial inflammation. High blood pressure, hypertension, migraines, excessive alcohol. Folks, how many times a day do you have a drink? Oh, no big deal. I only have it with lunch and dinner. Come on, that's excessive on a regular basis. Severe coughing or vomiting. Look for a tick. Someone's got a tick. Hormone replacement therapy or contraception issue. Excessive vessel torture or atherosclerosis. Moyamoya disease, radiation necrosis, and illegal drugs. All of these weaken the integrity of the vessel. They create a friability of the vessel. So you have to ask all of these questions. Then we get into my favorite word. This slide is going to be your guiding mantra from here forward. It's the word sudden. If you have a sudden headache, sudden dizziness, sudden balance disorder, sudden migraine, sudden vision change, sudden strabismus, crossing of the eyes or diplopia, sudden hearing change or cognitive loss. Even if these symptoms are transient, follow the stroke examination protocol. And we're going to give that to you. You must be on the guard for sudden. It came on suddenly. That means there could be a sudden change in fluid and blood to the brain. And that is the biggest red flag you will ever see. Sudden. And I'm going to give you a spoiler alert for the protocols, which are going to be in a few slides. Send them to the emergency room immediately. I don't care if the ER doc laughs at you, yells at you, thanks you, berates you. I don't care. Send them to the ER because you might save their life. And I have to tell you, out of the hundreds of doctors, there are dozens of people whose lives have been saved because they had a suddenness and all they heard was the back of their head. It's a hard Mark rule. Mark said, I got to get him there immediately. And guess what, folks? You have to get them there immediately. Then we get into vertebral, basilar, circulation orthopedic assessments. There are certain orthopedic tests, such as main sign, Barré-Liu sign, declines, vertebral artery test, which is no more really than turning the head, extending and holding it in different positions. They all have a low level of reliability. Should I say that again? A low level of reliability. They're not great, but it's all we got. So if someone, and by the way, they take about 30 seconds, not even. I do this on every single patient I go to adjust. Every one. I do a quick vertebral artery test. And I had one doctor, he was an oncoradiologist. I bent his head sideways, I lifted it up, I turned it all actually, far right rotation, full extension, hold it. I thought he was going to fall over. Guess what? He had no other sign or symptom. I had him go get an MR angiogram. He did that with actually Dr. Perkins, he did it with. And he was clear. And it was just one of those positional things, and I was able to adjust him. But I wouldn't touch him until he got medical clearance from a specialist on vascular assessments. So again, very low level of reliability, very low. But there's some value in it, and it just takes a few seconds, and we do it anyhow. So here's your protocols. I call these the Studin Perkins stroke protocols. I would have called it the Perkins student stroke protocols, but you get tongue twister in there. So this is a standard for trauma and non-trauma for each patient. Each class must have a basic neurological evaluation by any type of primary care provider. But guess what, folks? It is unconscionable for you, the chiropractor, not to do a complete neurological evaluation. It takes under 4 or 5 minutes. You have to do it anyhow. You're treating mechanical spine issues. You need to know what's going on. It is unacceptable not to do one. No risk, zero. You have a positive vertebral-basal or orthopedic test. There's no risk. Now, number 2 or more, over 55, diabetic, high blood pressure, obesity, previous stroke or heart attack, sleep apnea, heart or circulatory, and vertebral-basal orthopedic test is negative. This is mild. You're going to use your clinical judgment. Maybe get the medical records from the primary care provider. Okay? So that's something you might want to talk to them about. Or if you have a relationship with a vascular neurologist, that would be great. Number 2 is moderate. Any of the risk factors for infectious, cardiac, autoimmune, and obstetrical complications and sudden, mild to moderate changes in chronic, not post-traumatic changes, stroke or symptoms. We talked about that, migraines, dizziness, etc., and positive orthopedic testing. Okay? It's real easy. You're going to send them to a vascular neurologist immediately. And if there's not around, so you got to have a relationship with a general neurologist, you might want to consider an MR angiogram and a brain MRI. I really wouldn't want to do that. I'll get to that in a minute. Class 3 is severe, sudden, headache, dizziness, balance, etc. If they have sudden, this is mild to moderate, not post-traumatic change, but hit me like a ton of bricks to the ER. Now, I'm going to read this, then I'm going to give you a little bit more hard protocols. If any test for vertebral-basal insufficiency is positive at any level, then immediate MRA or referral to a vascular neurologist is indicated as protocol without touching your patient, folks. Not to adjust them in their lumbar spine. I'm going to do a genie rub on their right foot. Do not touch without prior written clearance for conservative care. Not chiropractic care, because they don't know chiropractic. Conservative care. Now, here's my hard rule again. I would never order an MRA, an MR angiogram, or a brain MRI. I wouldn't, because then I'm responsible for what's here. I know what to triage out, and I'm going to let someone else who's a lot smarter than I am be responsible for that, who looks at them all day long and who understands it. But you need to find someone. If you're away from a major teaching university, there might not be a level 1 stroke center. There might not be a vascular neurologist anywhere near where you are. You're going to have to make those relationships up front. And if I have a class 2 or a class 3, a class 2, I'm going to get that patient within a day or two. I'm going to call up that vascular neurologist or the neurologist who's good at stroke, and I'm going to have a conversation. Do you need to get them immediately? Do they need to be referred out? If number 3, they go to the ER. But number 2, I'm going to have an immediate conversation. And it might even be the ER doc. And I would err on the side of caution and send them. It's very simple. So these are your clinic protocols. Class 0 or 1, I'm not overly concerned. When it gets to 1, I might get the records from the medical doctor as long as these tests are negative from the primary care provider. Class 2, I'm going to have a conversation with someone while they're in my office in that visit. And I'm going to refer them out to the vascular neurologist or the neurologist for an evaluation. Number 3, right to the ER. I will not touch them without prior written clearance for conservative care. And I am not going to be ordering an MRA or an MRI of the brain. This is for the vertebral artery, and the brain is for the circle of Willis. And there's a couple of things I want to discuss. There are certain drugs that if patients are taking, even prescription drugs, that can increase risk. I'm not going to get into it in this brief conversation. You really need to take the full credentialing course with Dr. Perkins. She's the expert on that. As far as adjusting patients, a normal chiropractic rotary adjusted is not contraindicated if there's no other risk factors, and you do as you've been taught in chiropractic college. The other thing is if someone's undergoing a vascular incident, you're going to have class 2 or class 3 most likely. Sometimes not. Sometimes you're not going to know, but almost always you're going to know. That's where those orthopedic tests, again, which are very low value for reliability, but something's there. You've got to learn all about those questions. So when someone has neck pain, you might want to delve into it a little bit more. So there's a lot that needs to be learned about this and a lot of background information. Now, folks, this type of adjustment, and it's called the Condyle lift, a sharp cephalad, positive Y in the world of physics, sharp up top, Condyle lift, just sharp jerk. I've had that done to me. I saw my ancestors. I want you to know it was terrible. I would never, ever do that to a patient. That's my personal feeling. It does have a positive effect, but in a very lengthy conversation with Dr. Perkins, who has been a chiropractic patient for a long time, I put her in the position. I started doing that type of adjustment maneuver, and then I stopped, and she said I would never, ever do that on a patient, ever. And I agree with her 100%. The other is if you're going to put someone in a positive Y, that's straight up this type of traction, I'd make sure you have formal training in spinal biomechanical engineering or functional neurology, credentialed through a professional academic institution, and limited to providers who can diagnose and prognose neurovascular conditions. So be very careful, because some people take a bag and they just drop it, okay? A weight, and they just drop it, and then same thing, straight up for the head goes short. You got to be really careful with this stuff. There are certain things that I'm very cavalier and confident about, and other things, folks, I'm just more cautious. So, folks, thank you for allowing us to share the honor, of sharing all this information with you. On behalf of Dr. Candace Perkins, who the entire chiropractic and medical primary care community owes a great debt of gratitude for spending her time to do that with me, Dr. Don Capoferri out of Georgia, and again, the late Dr. Frank Zolli for putting this together. If you want to get formally credentialed or learn a whole lot more to have a super duper comfort level, go to teachdoctors.com. Look for the Stroke Anatomy and Evaluation for Chiropractors and Managing Medical Specialists. It's 8 CE hours approved in every state in the country who allows online CE. There is a special discount for ChiroSecure clients. You get credentialed through SUNY Buffalo Medical School, in joint partnership, Cleveland University College of Chiropractic. This course is highly credentialed and taught by the best in the world. So folks, again, go to teachdoctors.com. Again, I'd like to thank ChiroSecure so much for giving me the opportunity to share this information. The better you are, the safer your patients are. So I'd like to just, again, thank everyone for taking the time. And if there's any questions, just give me a call. It'll be my pleasure. Go to teachdoctors.com and learn. Have a great day.